Welcome. Thank you everyone for joining. My name is Natalie Shenneman. I'm the Advocacy Manager for the G4 Alliance, which is the Global Alliance for Surgical, Obstetric, Trauma, and Anesthesia Care. We are an 80-member civil society coalition dedicated to advocacy for the neglected surgical patient. And we're committed to a vision of universal access to surgical, obstetric, trauma, and anesthesia care. As part of the work of the G4 Alliance, our representatives of our member organizations have formed 17 different working groups. And one of our working groups is the Pain Management Working Group. It's a fairly new working group. A lot of what our groups are doing is, developing advocacy around specific issues, and also doing some of the advocacy is internal to provide education and promote specific issues and topics among the member organizations of the G4 Alliance that are focused on all different things. So the Pain Management Working Group is doing a little bit of both and is very glad to be working with WFSA today to bring you today's interactive session on essential pain management. So with that, I will turn it over to Claire to start us off. Thank you so much.
Thank you very much, Natalie, and thank you for inviting us to speak, arrange this webinar. So welcome everyone. This is going to be an online discussion about the Essential Pain Management Education Programme, and thank you very much for joining us. My name is Claire Rokes, and I'm the chair of the Pain Management Committee of the WFSA, that's the World Federation of Societies of Anaesthesiologists, and I'm based in Windsor in the UK. Just to go over a couple of technicalities before we start, and just to reiterate what Natalie has said, the meeting is being recorded and will be available afterwards. Because we are running this as a meeting set up rather than a webinar so that we can be interactive if we need, we would ask all of you who are not speaking to be on mute and to have your cameras off whilst we're not having any questions, so just for the first part of the session. And we may, if necessary, if you forget to do that, and if it's interrupting the speech a little, then Natalie may mute you. Please use the chat function if you've got any problems with the technicalities or you want to send us a message. As Natalie said, some of you will be joining us from Spanish-speaking countries. If you do want to hear the discussion in Spanish, or indeed if you want to hear anything that may be interpreted back into your own language, so even if you're an English listener, it's probably worth going to the globe icon at the bottom of the screen, or in the top right-hand corner if you're on a phone where there's 3 dots, selecting the globe and then choosing your language, either English or Spanish. And just a reminder to our speakers and to me to ask you to speak clearly and at an appropriate pace. The session will be about 60 minutes, and we'll start with 3 presentations taking about 30 minutes, giving us an overview of essential pain management, EPM, and the look at its global impact. And then we'll have 30 minutes for a question and answer session, which is an opportunity for you to ask our panelists any questions you may have. So please feel free to send questions in the chat function at the bottom of your screen. And as the session goes along, we'll answer as many of these as we can. At the end of the session, it would be great if we could have a photo of everyone. So we'll ask you to turn your cameras on if you're happy to do that at the end. So thank you again for joining us. And I'll now hand over to our 3 panelists to introduce themselves. Roger.
Thanks, Claire. And I'd like to also welcome everybody that's come to listen to some champions talk about pain around the world. My name is Roger Gook. I'm a pain medicine physician in Perth in Western Australia, and I'm really delighted to be here sharing my limited knowledge about pain management. And I'll come back to you soon. Claire.
Hi, I'm Mary Cardoza. I'm a pain doctor from Malaysia, and also a member of, IASP, the International Association for the Study of Pain. And I have been working with Roger to do some training in pain management, basic pain management in this part of the world, my part of the world, which I will be talking about afterwards. Over to you, Carolina.
Hello, everyone. I'm Carolina Haylock-Lore, anesthesiologist and intensive care physician from Honduras, Central America, as well as interventional pain physician, director of programs of the WFSA and chair of Diversity, Equity, and Inclusion Committee of the same organization. I am also the member of the EPM steering subcommittee. So I am so pleased to share with you our experience about the EPM journey in Latin America. Thank you very much.
Thank you, all three of you. And so we'll go over to Roger now to start with, to begin with his slides. Thanks, Roger.
So I'd like to begin by setting the scene, I suppose, about the challenges that we have with pain medicine and pain management around the world, and say a few words about the global burden of pain, talk a little bit about some pain management barriers, which we see in both high and low income countries, and then touch on some of the solutions. I've got no real conflicts of interest, only that I was a co-author with my good friend Wayne Morris to start the Essential Pain Management Program, which we'll touch on in some detail later on. So globally, the World Health Organization back in 2011 estimated that was about 5.5 billion people out of 7 that do not have access to treatments for moderate to severe pain. Now, you'll know that in 2023, the world population is 8 billion. So this 5.5 will have escalated up a little bit, but the ratio will be the same. And essentially, there is a large percentage of the world where there is no effective treatment for pain. So when we think about pain, we can simply divide it up into acute pain, cancer pain, palliative care, and then this huge area of chronic non-cancer pain. So acute pain comes from many, many different arenas: surgery, trauma, motor vehicle accidents, motorbike accidents, childbirth, and then some special areas, for example, sickle cell disease. And it's interesting that trauma account for about 30% of the global burden of disease. And as the number of personnel that are now available to offer treatment for surgical illness and provide surgery and anesthesiology, we're going to have an effect on the acute pain pre-surgery, but also the acute pain post-surgery and how we manage that, and possibly also post-surgical pain. So surgical disease and trauma are a huge component of the global burden. Cancer pain, palliative care, care at the end of life is a challenge, and we're fortunate to work with our palliative care physicians in attempting to address this issue. Cancer, of course, is a challenge not only because of late presentation, but also in many areas of the world, even with late presentation, there's limited treatment options. So we're looking at cancer pain and end-of-life care. And then there are non-cancer but life-limiting conditions, for instance, HIV/AIDS. And although there may be some treatment options available now for this group of patients, there are a lot of HIV neuropathy conditions that patients continue to have. Another interesting figure, although it's 2015, is 8.7 million deaths from cancer. Now, not all people who have cancer have pain, but 80 to 90% of them do in the last 3 to 4 months of life. Chronic non-cancer pain in low and middle income countries was always seen to be a bit of a Cinderella, or an area where people were not very focused. There have been some recent good studies, one from Jackson from the US in anesthesia and analgesia in 2016, which looked at the prevalence of chronic pain in low and middle income countries. And I guess not surprisingly to many of us, found that it was at least as high as in high income countries. So we're talking about back pain, headache, pelvic pain, the neuropathies. I've mentioned HIV, but there's diabetic neuropathy, post-amputation pain from sepsis, peripheral vascular disease, diabetes, and of course this unknown burden of chronic post-surgical pain if that becomes a challenge. So pain in low and middle income countries. So pain is more common in cancer, it's more common in HIV and more common in trauma, and treatment is often inadequate or non-existent. So there is a big challenge for us. So what are the barriers? So low prioritization. I suppose if you're the president or the prime minister of a country at war, if you're concerned about nutrition for your country, you're concerned about the economy, you're concerned about fresh water, you're concerned about HIV, about vaccinations, maybe pain relief is not a priority. So there's an issue there from a political perspective. We have patient expectations. A lot of patients will have had pain and seen pain throughout their lives and just expect it is part of life. So there's not only the expectations that nothing can be done or will be done, there are the patient attitudes. And this is reflected too on staff attitudes. And we know that staff knowledge about pain management is limited. Low staff numbers. It may be that healthcare is not a high priority for many people in low and middle income countries. How do we recruit more people to be interested in and manage pain, both medical staff and nursing staff? Access to medications, a big challenge. I'll mention that again in a minute. The challenge with opioids, again, I'll come back to that as a barrier. And then, of course, I guess related to priorities are the costs for the community and for the country, and then having good data to measure the amount of challenge that we have. We know in terms of opioids that 90% of opioids around the world are used for 20% of the population, and this is mainly in high-income countries. We know that there is fear of opioids, fear of morphine, because of exaggerated fear of side effects, mainly because of inadequate knowledge and inadequate usage. Opioids can be used quite safely, but we haven't been able to get the information out either in high-income countries or in low-income countries. And there's a concept that pethidine is the safe morphine. In many high-income countries, pethidine is no longer used, but if you're in a low-income country and it's the only opioid, it works really quite well, but not as well as morphine. So the lack of oral morphine is a challenge postoperatively, it's a challenge for cancer patients, and a challenge in children's pain management. And we have this term global opioid craziness, where there's too little or no opioid causing patient harm, which is really worsening pain in many low and middle income countries, versus this too much opioid with patient harm in many high income countries. And I'm thinking about the US, Western Europe, and to a certain extent in Australia. So what are the solutions? Well, advocacy, and it's really good that we can share the platform with the G4 Alliance to help with advocacy. We can try and improve treatment availability, and we can do this by education, education, education. In terms of advocacy, the WFSA has been lobbying the World Health Assembly on a couple of occasions over the last few years, and at least has these challenges on the agenda for the WHA. Improve treatment availability through the World Health Organization and their Essential Pain Medicine Program. A number of global lobbying agents are trying to address this, and it's good that that's happening, although it's not been rolled out around the world very well. We need to focus also on non-opioid treatments, both pharmacological and non-pharmacological, and EPM tries to do that. EPM has been delivered in very diverse countries from Mongolia to Malawi. So what is EPM? It's a mechanism to promote recognition, assessment, and treatment of pain. It's a one-day interactive workshop. It's aimed at doctors, nurses, and other health workers. It's also a system for managing pain. And attached to it is a system for teaching others about pain management. It was launched in 2010 and up to 2020. This is a little bit of an old slide because of COVID, but there was about 61 countries in the 2020-21, 10,000 participants and 2,000 instructors. And Carolina and Mary will talk to you a little bit about that in some detail. From a global perspective, we know there's a high burden of pain in LMICs, low and middle income countries. Treatment is often inadequate. We need an approach to opioids, which is more realistic than currently is. And we feel that education of undergraduate nurses, medical students, and then the existing healthcare practitioners is the way to go forward. There is an essential pain management online program, which can be accessed. It's free from this www.praxhub.com. And if we have time, we can show you some more detail about this online learning program. So I'll hand you over now to Mary, who's going to talk to us about EPM in Southeast Asia. Thanks, Mary.
Thanks, Roger. I think So my role is to talk about what we have done with EPM and how it has made an impact in my part of the world, which is Southeast Asia. I put plus because I'm also going to include Hong Kong. Just a little bit of my personal involvement. I started teaching or learning about EPM when Roger came to run a workshop in Sarawak in Malaysia in 2012 or something like that, a long time ago. And since then, we haven't really looked back. So we have it. The attractive thing about EPM is it is a program. I think we will play a video that shows you more details about the program, but basically it is a simple program that is suitable for all healthcare practitioners, whatever level you're at. And we encourage mixed, a multidisciplinary audience. So you have, and it's an interactive workshop, generates a lot of discussion, and and we have different workshops for those who are already for healthcare practitioners, as well as for students, medical students, nursing students, etc. We ask them basically to talk about their own experience, and we really try to make it so that they can apply it and use the knowledge that they have gained at the workshop immediately the minute they go back to their workplace. So in this region, we have had good uptake. And we have run it in all these countries that you see: Myanmar, Cambodia, Laos, Thailand, Indonesia, Philippines, Malaysia, Vietnam, Hong Kong. And India, I didn't include India, Pakistan, Nepal, where it has also been run, but because it's just too vast a region, and I haven't been personally involved in those teaching EPM in those regions. But the other thing about EPM is that it has been translated into many languages, and the slides and the manual, we have slides, we have a manual for participants as well as for instructors, and everything is simple enough for the local people to do the to translate, to do the translation. So Vietnamese and the people in Cambodia, for example, have done the translation before we go and run the workshops there. Same with Indonesia. And so, we sometimes have the slide up in Vietnamese, but, we know the slide so well that we can speak in English to the Vietnamese slide. So anyway, we try as much as possible to localize both the examples and the situation that they are facing in their own countries. And so we always try to have it together with an instructor workshop to train some local instructors who then will run on the third day another series, another workshop with us as observers. So it is not just a workshop for healthcare professionals, it's also to train instructors. And I think that that is one feature that makes it powerful and also makes it continue. So in 2012, I mean 2021 with the pandemic, we had to convert to virtual sessions, but we didn't give up completely. We just converted to virtual, and the program was able to do that. And of course, as Roger mentioned, we now have an online version. So this is what we are promoting. The online version does not have the opportunity for the participants to take part in case discussions, to practice the use of the RAT, recognize, assess, and treat. But at least it gives the basic understanding of pain from a biopsychosocial perspective. So the features really are very important for people who want to promote this biopsychosocial multidisciplinary approach to pain management, which I think is lacking in many parts of the world, including our region. So, okay, how have we, how has the uptake been in the different countries in this region? Really quite different. In Malaysia, we managed to incorporate the EPM, RAT, recognize, assess, and treat approach to pain management in our National Ministry of Health training on pain as the fifth vital sign, and in our pain-free hospital program, and in several universities, EPM Light is taught for medical students. In Thailand, it's mainly nurses and also medical students. In Indonesia, is limited to a few places with champions, for example, Makassar and Surabaya. And now I think in more places as well. In Myanmar, Cambodia, and Laos, there's no core group that's running regular training. So although we have gone there, they don't do it on a regular basis. But in Vietnam, we are very pleased that there is now a young group that just has started. We just ran an online training of trainers, and they are taking it and going to run regular EPM workshops. In Hong Kong, the training is done through the hospital authority. And in the Philippines, I wanted to highlight the Philippines because what has happened is that the Philippine Pain Society has actually taken this up as one of their core activities, one of their regular activities, and they run regular hospital-based workshops all over the country, as well as EPM Light for students. So this is next slide, Roger. Okay, sorry. So what makes the difference in uptake in different countries? Why is it some countries have taken it and run it regularly and others don't? I think the main thing is that they are local champions. Importantly, also, if you get support from a society, institution, or Ministry of Health, for example, you can run it on a regular basis. Of course, resources is always a challenge, Back to the previous slide, Roger, sorry. And I just wanted to mention here that, there have been a lot of, the IASP has a developing countries educational grant, and they have we have funded a number of EPM projects, training projects in low and middle income countries. Okay, next, Roger, this is just to show you a slide taken from Dr. Joy K from the Philippines. This is again a bit dated, but because they run the workshops regularly, Roger and I went there maybe a couple of times, and they have actually just run it on a regular basis. So all over the country, from in their many islands that they have. So this is just to show you that, and the next one is to show you that there have also been this is from Papua New Guinea, where it was first started, and looking at the impact of EPM, which showed we have a pre and a post test, and there was some improvement in pre and post test scores, of course, which is expected, but importantly that there were behavioral changes with increased knowledge leading to changes in clinical practice, increased use of multimodal analgesia, increase educational activities to other healthcare professionals, and actual use of RAT, the Recognize, Assess, and Treat system, which we teach in EPM. Next, which is the last slide. Yeah, just to show you that anesthesia and analgesia actually had a few articles that looked at EPM as something that should be promoted globally in order to improve pain management around the world. So I think that that is what I have to share with you today, and I'm happy to take other questions. So Carolina.
Yes, thank you very much, Mary. Happy to share with you all the EPM journey in Latin America. As you can see, last year we celebrated our 10th anniversary. We started in 2012, and it was we were so happy at Bolivia CLASA meeting to celebrate our 10th year. Okay, so in Latin America, we started in August 2012 in Honduras. And since then, it has spread to our region, as you can see in the slide. And this is our story. After 11 years, we've been teaching in the region, bringing fast local ownership through a cascade model, training anesthesiologists as the champion that will multiply the knowledge. To now, 17 Latin American countries, only missing Brazil and Cuba. We have trained more than 162 instructors, run more than 61 EPM workshops, and with more than 2,000 approximately attendants. And during the pandemic, from 2020 to 2022, we had more than 8 virtual courses, and 5 of them were EPM Lite, and 1 was the virtual for instructors, the virtual modality for instructors, 2 PM, 1 in full day virtual, also in Colombia. Mexico, Bolivia, Argentina, and Colombia has been very active during the pandemic and post-pandemic. Post-pandemic, 4 EPM in-person courses, 1 hybrid, and 3 in-person. So as you can see, we have been very active. Let's pass the next slide, please. This very busy slide is to show the abundant harvest in Latin America. Even in pandemic, we didn't stop because pain doesn't wait, and education in pain has to continue. Therefore, you see the multiplying factor of the EPM program in our region since we started in 2012. During the pandemic, we didn't stop the education in pain, as I said, and we ran more than 8 courses, trained 17 EPM instructors in virtual modality, and we went to medical schools with 4 virtual courses of EPM Lite and 1 virtual EPM full day course, as I said, for Colombian anesthesiologists, also virtual. Next, next slide. Yes, and this is during the fall, during the World Congress of Anesthesia in 2021, we launched the EPM online, but we also had this opportunity to train the virtual EPM trainer workshops, and EPM online was launched. As I said, this virtual modality with asynchronous and synchronous modules, it is becoming more popular for the region, and we know even more after it comes in Spanish. Then I think 1 slide more and we almost there. So we started with EPM Lite in October in 2019 in person. We continued during the pandemic teaching essential pain management in several med schools. In Uruguay, we are starting to include this course in the curricula of one of med school, And in Bolivia, the Minister of Health included this course as part of the induction process for physicians and nurses working in primary care centers. Therefore, I can say we are glad with EPM journey in our region with local ownership and sustainability of the program. The challenge, of course, is monitoring of evaluation. Of course, it is contextualized. Healthcare workers are trying to overcome their barriers at their facility, at their system, but still some countries do not have, for example, morphine syrup. Others don't have slow release morphine, or they ran out of opioids in general at mid of the year. So the struggle is persistent. But in general, I can say we are so glad all the materials are translated to Spanish, the slides, the manuals, instructor manuals, participant manuals, EPM Lite. So we are so glad with this course in our region. I thank you very much.
Thank you, Carolina, and Roger, and Mary, of course. That was a great overview. Thank you. We've had a few questions coming through. But Mary and Carolina were thinking it would be good to have a little bit more on the content of the workshop. So I'm wondering whether we might show a short video that we've got of one version of the course. Roger, do you just want to say something about what EPM is, which is the video, and then we'll go to the questions?
Sure. As Carolina said, the pandemic really shut us down in terms of how to deliver education. And then we became Zoom friendly and Zoom confident. And then we realized that we should probably be trying to do more. And so with the slides that we were presenting over a long day, 6 to 8 hours, which were in fact interactive, we decided that we could put most of the slides into an online semi-interactive learning module. And this is now in its second version. We launched the version at the World Congress in September 2021, and it's now been slightly modified, and it's about to be released in Spanish. And so we've got this video which will give you a feel of how to use it, how to access it. This video is in English, and the program, the online program we're talking about, is also in English. But as I said, in the next month or so, we hope that the Spanish version will be available, and it will be slightly different, obviously, although it's in Spanish as well. So. Claire, do you want to show it, and then we can answer any questions afterwards? It's about 6 minutes.
The Essential Pain Management team are pleased to launch and introduce to you the EPM online training module, which is now available. This training module has been developed through a partnership between the Australian and New Zealand College of Anaesthetists, Interplast, the World Federation of Societies of Anaesthesiologists, the Australian Society of Anaesthetists, and the International Association for the Study of Pain. We are grateful for the financial support of ANZCA, the Australian Government, and Interplast, which has enabled this module to be developed. EPM Online was developed in close collaboration with and guidance from course authors Dr. Roger Gook and Dr. Wayne Morris, and takes all of the teaching and concepts from the full-day EPM face-to-face course and puts it into an interactive, online, at-your-own-pace module. Much like the full-day EPM face-to-face course, EPM Online follows the Recognise, Assess and Treat framework, or RAT. EPM Online is hosted within the PraxHub platform. PraxHub is an organisation based in Melbourne, Australia, which uses technology to connect healthcare professionals with education providers to achieve better health outcomes through access to a high-quality education. PraxHub is free to join for all healthcare professionals. Once you register, you can subscribe to different education providers within Prax Hub and access free education content. To register, you only need to enter a few basic details, including your country, profession, and specialty. These details will help the system recommend more relevant education to you as a member. Once you have registered and logged in, you will see this screen with a list of all of the different education provider organisations. To find the Essential Pain Management page, you can either scroll down or you can search in the top search bar. Once you find the page, you should click on the blue Follow button so that this page will always appear in your My Organisations list. Click on either the All Education tab or access the module directly from the sidebar. This is where you go to begin the EPM online module. Prax Hub is a fully responsive site allowing the module to be accessed from any device, including laptop, tablet, or mobile phone. This was an important consideration to ensure greatest access to the education, particularly in countries where access to computers is more limited. Start to finish, the EPM online course will take you approximately 2.5 hours. You don't need to complete it all in one sitting. You can stop, go away and come back at your convenience, and the course will remember where you are up to. EPM Online has a pre and post course test and a number of mini quizzes along the way to test your understanding. You will need to achieve an 80% pass rate in the course's final test in order to successfully complete the course and receive the completion certificate. But you are able to attempt this test as many times as you need, and you can go back and review the course content if you need to. EPM Online includes 8 sections. There is an overview which introduces the course and its background and outlines who was involved in developing the course. This section also includes the overall learning outcomes and some initial introductions to pain. A short pre-test will assess your understanding of the course content before you begin, so that you can then undertake this same test following the course to see how your understanding has improved. The course begins with the first part of the RAT, Recognise. This section teaches the student to define pain, understand the biopsychosocial model of pain, be able to recognise pain in children and adults, and list the benefits of treating pain. The next section, Assess, takes the student through understanding different ways of measuring the severity of pain and classifying different types of pain. It teaches how to evaluate other factors which might be affecting the patient's pain. Finally, it takes the student through an understanding of normal pain physiology and to be aware of abnormal pain physiology. In the Treat section, the student is taught where treatment works in the nervous system, introduced to the terms multimodal, multidisciplinary, and interdisciplinary, and to the role of the placebo effect. Pharmacological treatment options are explained, as is the importance of non-pharmacological treatment options. The concept of addiction and its relation to the use of opioids is covered, as is the importance of reassessment once treatment is provided. The course then takes the learner through 4 detailed case studies demonstrating the use of Recognise, Assess, Treat, and Reassess. The post-course test is then given to assess improvement in knowledge, followed by the course evaluation, and then access to the resources section, which contains further links, tools to download, and other information. To engage the learner, the course uses a number of different interactive tools to deliver the education. This includes short explanatory videos to cover key concepts, flip cards, interactive moving diagrams, and the opportunity to pause and reflect on their own clinical situation and how these concepts may apply to them. Regular mini quizzes also check that the learner is following the concepts being taught and reinforcing key messages. Once you have achieved the 80% pass rate, you will go back to the course page on the Prax Hub platform and be asked to complete a short evaluation. Participants can return to the course at any time directly from their CPD history page, which also tracks their CPD hours across the entire platform. Here you will then be able to download a completion certificate to use for your CPD or compliance reporting purposes. The course is now live and people can sign up to complete it. To get started, visit the link on the screen, register, and then you'll be directed to the course. Plans are in place to translate the EPM online course into Spanish in coming months. This will be communicated through the EPM newsletters, so if you don't already receive them, we'd encourage you to sign up. You can also follow the EPM Facebook page for course updates. The EPM faculty will be running small group case discussions, those who have completed the online course, to facilitate group discussion and build on the learnings of the online program. These will be held 5 to 6 times a year via Zoom. Those who have completed the course will be contacted to register for these sessions. EPM Online will be reviewed periodically and updates will be made as required. We encourage you to share the information about EPM Online far and wide, and we hope that you find it beneficial.
I might follow that up, Claire. So one of the things you'll see just as the video was finishing is that doing EPM online, there is no interaction.
Sorry, everyone.
You're just interacting with the questions. And so one of the things that we thought we could try, and we've done it once or twice, is that we could facilitate by Zoom a case discussion group. Although this would be better done if it was done locally in a country or a city, but it would be possible for us to do it from Australia or Malaysia or Honduras or London. It would be possible. So that's something else that we wanted to try and facilitate, to make sure there was a discussion, one could ask questions and run through some real cases, which could be cases we use in EPM, or people could be encouraged to bring their own case and use the RAT approach for it.
So, Roger, I just add to that. What we have done as well is to get to use EPM online as a basic education for those attending a pain workshop. For example, in Southeast Asia, we ran some training on multidisciplinary pain management at a different level. And so they had to do EPM Lite, but when they came EPM online, but when we first started the workshop, we actually had a session which gave them an opportunity to ask questions as well as to have the case discussions, so that people can actually practice using this recognize, assess, and treat RAT approach. I think, and we are doing that in some of our hospitals as well, get our younger doctors and nurses and physios, etc., to do the online course and then get them together for a face-to-face case discussion. So I think it's very useful in that sense. It cuts down on your workshop time. You only need an hour instead of 8 hours.
Thank you, everyone. Thank you for that. So I'm going through some of the questions. The one question that's come up in a couple of different formats is people are very keen to get involved in EPM and to become instructors. So how can people do that? Roger, do you want to, or maybe, yeah, Roger, do you want to take that?
Yeah, Roger.
So just repeat the question for me, Claire.
How do you become an EPM champion or an EPM instructor?
So I guess Carolina and Mary will be able to help me here. So when we go to a country, we clearly have to be invited by someone in the country, and because our contacts have been primarily anesthesiology, it's usually been through somebody in the anesthesiology department, but not always. And we have had invitations from palliative care workers and from general physicians and indeed surgeons. So once one's in a country, a city, a hospital, we need to be able to find somebody who will take ownership of this. It may be the director of a department, or it may be somebody who's very enthusiastic, maybe a nurse, a senior nurse in a hospital. It's then really up to us to support them through their own resources to then try and grow enthusiasm for what we would say is a pain champion. It's someone to be a link to provide information. Now, the more senior the person is, if it's the head of the department or the head of the hospital, which has happened, and Mary has been able to get the Ministry of Health and the Minister of Health engaged, and so has Carolina in La Paz, I think, Bolivia. So if you can do that, then clearly it's much easier if you've got senior members of the hospital system or senior members in the political system to help you. But it will still need a champion at the ground floor to do a lot of the work and to engage with other medical and nursing staff to actually become the instructors and teachers. But to have a senior person behind you, supporting you, is key as well.
Yeah. Okay, Carolina, go ahead first.
Thank you, Mary. In Latin America, there are different countries that already has its own coordinator or champion. So I put in a chat right there for the speaker, English, Spanish speaker colleagues that are interested in being in EPM instructors, so they can write to my email, and then I can refer them to the coordinator of the country. Of course, we are missing some countries still, but we're going for that too. But anyway, we will get them to know if there's any opportunity of train as EPM instructors on virtual modality. So that has been a very good opportunity. Of course, one of the positive things that came with the crisis was to become Zoom friendly, as Roger said. So it will be, there's always opportunities of training. Thank you.
So the other thing that we have done before is we have run EPM as a pre-congress workshop for anesthesia congresses or palliative care meetings, you know. And we can either do it as just a half-day workshop, one-day workshop, or you know, the 3-day program with instructor training as well. So basically, it's up to you to contact EPM, contact Roger. I guess Roger, sorry, I will. Roger has written his email in the chat, and then, you know, we'll take it from there. You know, and you have to organize your local logistics, etc., and you know, funding is another issue which we can talk about, which we can discuss, you know, with each individual who wants to run EPM in their country. So there are, like I said, the Philippine Pain Society has taken it up, you know, so it could be taken up by a pain society, it could be taken up by anesthesia society, or it could be just taken up by a hospital or hospital a hospital authority like in Hong Kong. So there are many different ways of doing it, but basically the individual who is interested needs to contact us, and then we will take it from there.
Thank you, everyone. And just to add on that from the chat, if by getting in touch with us, if there was a comment that possibly some of the information wasn't up to date, in the sense that EPM programs have been run in places that we're not aware of. If you think you've run an EPM program and you want to let us know, then please do just get in touch with Roger via that EPM email address, and we will update the information. We're always very keen to know about what work is ongoing. Roger, do you want to say anything about the question about adapting the curriculum for different regions and different resources?
Well, there was a question in the chat about different medications that are only available in some countries and not in others. These are usually different types of non-steroidal anti-inflammatory drugs, or different types of opioids that are available in some countries and not in others. So in terms of that, we just have to adapt when we're there. And if we're running a program in country, the local champion would advise external teachers, external instructors, what the situation was in that country. In terms of different conditions, I think sickle cell disease is probably one of the conditions which many people find extremely difficult to manage. And we have developed cases on maybe best practice management for sickle cell disease. Now, if we're going to a country where there is no sickle cell disease, then clearly we wouldn't have that case. And in countries that have certain conditions more than others, or different areas of different countries, a metropolitan area may have many more road traffic accidents, for instance, whereas a rural area, there may be less. So I think the recognize, assess, and treat is the same throughout the whole system for educating. What changes is the way you apply it to different patients and different conditions, but it will work with somebody who's had a fall off a motorbike and got a brachial plexus avulsion, as it will in somebody with a pregnant woman who's laboring for a long period of time, or for a child with a ruptured appendix, or with somebody with HIV neuropathy. RAT will work on any condition. And so that's what we try and teach, is that it's applicable to anybody, and it's applicable to high-income countries. As we've said, EPM has been taught in up to 50 of the medical schools in the United Kingdom, and 3 or 4 of the medical schools in Australia and in New Zealand. So it works in a high-income country as it does in Papua New Guinea, where we've also got a lot of experience. So that the system works, we just need to adapt it to the environment, and it adapts very easily.
Thanks, Roger. Mary or Carolina, do you want to add anything to that, or should we move to another question?
Yes.
So I think that, okay, go ahead, Carolina.
I was thinking that this is, well, we are aware that this is such a global health issue, and it's, you know, independent of high-income country or low-income settings, or as Roger said, recognize, assess, and treat is the same for everyone. Some things must be contextualized, but you know, that's why the name essential pain management. So that means that we must get like the basis for everyone, you know, everyone speaking the same language. So that can be, I think that is one of our aims. And I really, really encourage everyone to, you know, to go for it, because it's, if we go not only like specialists, not only as general practitioners, but also as medical students and nursing students, everyone should know about essential pain management. Thank you.
Yeah, I was going to say that in terms of context, that's why it's important for us to have local trainers, you know, to train the local instructors, and we find that the dynamics is actually quite different. The interaction is much more when the local instructors run the workshop, which we will attend as observers. We sometimes don't understand what's going on, often because we don't speak the language, right? But when they teach it in the local language, you know, it's much more interactive, and I think more meaningful to the participants who are there. So I really like this model of having the instructor workshop on day 2 and the new instructors running another workshop on day 3.
Thank you. Thank you. I wonder if one of you would like to say something about sustainability of a program in a country, particularly with respect to how you might fund it and the ongoing issues with that.
Roger.
Okay. Well, I mean, I'm going to reflect on what you've done in Malaysia. If you have the pain-free hospital system going and you have hospital accreditation tied to meeting certain criteria for having a pain management program in that hospital, then that helps a lot. If sustainability has been demonstrated well in South America with the champions in South America that have been able to roll it out over that huge country. And we know in countries where we've been 1 or 2 or 3 times and it just hasn't had traction, it may not be a financial issue. It may be one of those other barriers. It's just not seen as a priority by the country. We just haven't, or there's been so many other pressures on the healthcare system. And Myanmar would be an example of the difficulties in that country with us running EPM in medical schools in numerous towns and across Yangon on multiple occasions. And the crisis that's there now has stopped all that. And I'm sure the healthcare workers will have benefited from it, but it's impossible to run teaching in Myanmar at this time. So that's just one example. So the priorities in the country will change. In the Philippines, we heard that the Philippine Pain Society, the Pain Association of the Philippines, has taken on that as a role that they want to run. And so we can support them, and they have a number of very fantastic champions doing the work in the Philippines. So it will depend on each country how to make it sustainable.
I just add a little bit to that, Claire. Just that all, this is something that is easy to use as a pain education tool, as I've mentioned before. And I just want to give the example of Vietnam. So there was this young anesthetist who did his pain fellowship in Bangkok. And when he went back to Vietnam, he didn't know how he was going to, teach other people, get other people on board about his way of thinking about multidisciplinary pain management and so on and so forth. So we just gave him helped him to run a program. And now they've built up a group in Vietnam who are going to run the program regularly. So if they see a need for it, that is also part of the sustainability. They will find it's not an expensive program to run because you can do it we encourage small groups, of course, we have 20 to 30 people only. And it can be done in hospital settings. You don't need a lot of, and now if you are doing it virtually, you only need to give your time and to organize something and to get a group of people together. So I think in terms of cost, it's not really a big issue. It's a matter of interest and seeing the need for it.
Just a few words to add to what Mary said and giving word to Elizabeth. I should say that this, in Latin America especially, this teaching tool has, pain teaching tool has empower also our national societies, because our national societies are the owner, like to say, or endorsing the whole course. So this is also a way to champion this EPM program. And of course, you have a coordinator of the program, but when you have that support of the national society, that can make it easier. Of course, Mary said you don't need much, you don't need much to run an EPM course in person, but less virtual. So if you join with your national society, you've done it. Thank you.
Yeah.
Thank you, Carolina and Mary and Roger. I'm aware that we're running out of time a little bit now, but I think we've probably got time just to hear from Elizabeth and Gaston, who both have their hands up, and then we'll wrap things up. So Elizabeth, do you want to go ahead?
Yeah, thank you so much for this meeting and for the opportunity to speak. And thank all the speakers for the presentation so far. I just want to respond to the issue of sustainability and funding. Like we've been doing EPM in Nigeria since 2016, and it's been adopted by the National Society, that's the Society for the Study of Pain Nigeria, and also by the Nigerian Society of Anesthetists. And we've even taken it out to other parts of West Africa. But the issue is the problem of funding. So I would like to know if there is any way that this problem can be solved. Because as a national society, we can do little, but maybe to support if we have some funding, but we cannot take up the whole responsibility because we have large crowds or large number of participants each time we hold the program, and it's really a lot to be able to do and to continue. So I really would love it if EPM can do more, WFSA, ISP, and I know ISP has supported us in the past 2 or 3 times. They've given us funds to be able to run it, and also the EPM itself, and even the WFSA. But we really need to do more in terms of support and in terms of funding.
Thank you.
Thank you so much. It's been a great opportunity to be a trainer and instructor and a champion of the EPM. Thank you.
Thank you, Elizabeth. Roger, thank you. That's great to hear. Roger, do you want to answer that?
I was just thinking that maybe, Elizabeth, in the chat, if you put your email address, we can have a discussion by email later on this week. Maybe some ideas.
Thank you, Roger. And Gaston, hi.
Hi, Claire. Hi, everyone. For this, I will jump in, thanking the presenters and whoever has been around doing this. And my only say is that we have been running EPM. This was introduced in 2012 here by Roger and Maurice when they came to Rwanda, and
Oh.
We've lost you, Gaston.
Yes, I'm afraid Gaston's been lost. I know Gaston's a great EPM champion.
away, but it took some few years later to start doing that. And what we did is to interest the hospitals. It was not run by the national society or anything national. At the university. So a small group of people organized themselves and got funding from the hospital, and then started from the hospital. And the time it took to start was because people were waiting for funding, and funding sometimes it's a big issue, and this may delay everything. So one option from my experience is to start from the institution you're working, and if you have like academic institution that can support you, that can understand what you did. It depends on how you explain and get buy-in, and then you might have some other organizations that can support in terms of capacity building. But the hospital, the academic institution can maybe help if they understand really that is something, it's a good model to use for training their staff. And it starts from the needs assessment. If people have not been trained in the hospital to treat pain, and you have people like patients not being satisfied with the service you give, then it's a good option and easy, accessible, and anyone can have access to that. So I think the important thing is to have like a concept note that can be presented to the hospital or institution you work in, and then try to talk like in person, and then might get funded from there. There are some training fees in the hospital, training some, it's not a big, like a big event, like a big conference. It's might start from the institution. Yeah, that's the word I can just to encourage people to run in the institution, start from there. Thank you.
Thank you, Gaston. That's really, really helpful. I'm wondering whether some of these conversations might be good to carry on afterwards too. So please do get in touch, and we are more than happy to put people in touch with anyone else who's got knowledge, and particularly of local champions, so we can easily facilitate that. I'm afraid we are running out of time because we have gone over our hour that's been allocated. But I just want to sum up to say thank you very much to Roger, to Carolina, to Mary. I think that was a great overview, and it certainly stimulated lots of discussion, and hopefully lots of ongoing discussion from this too, because lots of people are enthusiastic to get involved in this excellent programme. I will just hand over to Alan to do a little sum up from their end, but please just remember before you all go, it would be great to have a photo if Natalie can organise that with everybody's cameras on at the end. So thank you very much to our speakers. And Alan, do you want to say something?
Sure, just a couple of very brief comments. I'm sorry I was a little late. I was stuck in clinic and couldn't get out quite at the beginning. So as I put in the chat there, I think Natalie has introduced the G4 Alliance to people who weren't aware of it. And we started the Pain Management Working Group last year. As I'd been at G4 for a number of years, continually talking about pain management, they finally decided to let me do more. SOTA care, surgical obstetric trauma anesthesia care, surgical disease almost inevitably causes pain, and surgical treatment of disease almost inevitably causes pain. So pain management has to be integrated in all aspects of that type of care. And so that's what we're working towards. We're hopefully going to have a series of these webinars. Actually, Gaston gave a superb one a couple of months ago. And then we've had this one sponsored by WFSA, which is a partner in G4, to highlight this outstanding program, which just shows that you can do so much with relatively little investment and relatively little complexity and make a huge difference. So I encourage everybody to stay involved, connect with Natalie if you're interested in joining our pain management working group, connect with EPM if you're interested in championing a program in your area. My interest, of course, is pediatric, and I think Roger and the others would say that an EPM program could also have pediatric cases and be focused that way, as well as being focused on regional resources. So there's lots of flexibility in it to meet the needs of the local scenario. Thank you, everybody, so much for attending. Thank you to Roger, Mary, and Carolina for presenting. Thank you, Claire, for organizing it. And hopefully we'll see you all again soon. Cheers.